The content discussed in this episode may be specific to the guest's organisation or location and may not be applicable to other organisations, states, territories or countries. The material presented in this podcast is for general information purposes only and should not be considered health, legal or financial advice. Medical administration is a rewarding profession, but it comes with challenges. So what is it like, and what should you do if confronted with a monumental administrative difficulty? This is the podcast that takes unfortunate scenarios and explores the essentials of clinical governance to find solutions. I'm Dr David Rankin, a very experienced medical administrator and lead fellow with the Royal Australasian College of Medical Administrators. And this is Safeguarding Healthcare, the essentials of clinical governance. Today, the challenges of missed test results.
The first thing I would ensure is the safety and the welfare of the clinician.
That's Dr Margaret Wilsher, a respiratory physician who spent 13 years as the Chief Medical Officer at Te Toka Tumai, or Auckland City Hospital. Margaret is also a board member with PharmAC, New Zealand's medication and medical device regulatory and funding agency, and I'm presenting her with a difficult scenario.
It's a horrendous experience to either overlook or not have a system deliver you a result on a test that you ordered.
In today's scenario, an itinerant patient without a regular GP attends the emergency department with an annoying, persistent cough. The emergency physician diagnoses a likely allergic basis for the cough but orders a chest X-ray, which shows an area of non-specific change. A sputum sample is collected for culture and the patient is discharged 3 hours later. The patient represents to the emergency department several months later when they start coughing up specks of blood. A review of the sputum culture indicates the presence of TB. However, this result has remained unseen by the emergency physician, who only works on occasional weekends. The patient was itinerant, so had no identified GP, resulting in no results being sent out to the GP to review. I started by asking Dr Margaret Wilsher what issues this scenario raises.
Well, for me as a clinician leader with a role in safety, there are issues relating to the patient. There are issues relating to the community as the patient was potentially, if not definitely, infectious with a communicable disease, and it's a vulnerable community as he is itinerant. There are issues relating to the doctor as a second victim with a missed laboratory result of concern. And then there's issues relating to the system failing, if there is one, with a failure of a closed-loop process. So we have to kind of manage those things discreetly. The patient I would probably give to the clinicians after the necessary disclosure that we have this result and that we actually didn't act on it soon enough. The community will become the responsibility of the public health service, and so that service needs to be notified. But the doctor and the investigation, the management of that is very much within the bailiwick of the lead for clinical safety or the chief clinical officer of the institution. So those are kind of the buckets in which I will, I guess, put the issues and begin to approach the matter.
So let's start off with the clinician. I guess you've got really three parties involved here. You've got the doctor that ordered the sputum culture, you've got the hospital that he works for and his immediate supervisors, and then you've got the laboratory, all with potential liability or responsibility.
The first thing I would ensure is the safety and the welfare of the clinician. It's a horrendous experience to either overlook or not have a system deliver you a result on a test that you ordered that requires action. And I would apply the principles of just culture here. And I would not ascribe any sense of blame or start to apportion liability until I've investigated exactly what happened here. Now, we could apply a tool such as a root cause analysis, or we could take something simpler such as a method where you ask what happened, what normally happens, and what should happen. If in the course of that investigation it becomes apparent that there are performance issues relating to the doctor who ordered the test, then you can take that to one side and manage accordingly. But I would need to understand where the system potentially let this patient down and the community down. So that would require investigation. There are three, key junctures along the way. There's the ordering of the test, there's the processing of the test and the loading of that result by the laboratory onto a system. And then there's the system that should allow that test result to get to someone who can action it within a timely period. That might not be the orderer, depending on the system in which you are working. But I think understanding that and understanding if the system isn't resilient enough and there isn't appropriate redundancy is very, very important here. And some systems, for example, have two-factor redundancy where the orderer gets the result and can action, but the laboratory, in the case of an important result, can also notify directly any concerned people, such as tuberculosis. A TB laboratory would generally send a copy of a positive report to a public health service.
It's difficult in a scenario like this, which is not uncommon, that the emergency doctor works a shift 1 weekend a month or something like that. What happens to laboratory results when they come back after the doctors finished their shift and may not be due back in the hospital for a few weeks?
That's where I think the employer has a responsibility to ensure there is a system and inherent processes that ensure those results are acted on in a timely way when you have workers who are contractors in effect coming in and either doing locum shifts or doing shifts every 1 or 2 weeks. And the employer of the doctor, the host organisation or provider of the emergency service, is vicariously responsible for ensuring that its systems are safe for patients and safe for doctors and other clinicians to work in. So I would be looking very much at investigating to see where the system broke down. I anticipate, as so often has been found to be the case, that there won't be a closed loop here, and that we would then, having found that, would help the emergency department and other departments who might be so affected design a system with really robust processes to enable a result to be delivered to someone who can action it in the right time frame and appropriately. That will, of course, be in consideration of any IT systems and the linkage of them, and that can be difficult if your laboratory is an external laboratory, for example, and not an internal laboratory. So all of that needs to be considered.
Normally the emergency doctor would have said, no, CC the GP. But in this case, as so often happens with itinerant patients, they don't have a named GP. So who's responsible for following up the results?
That depends on who you ask. The regulators, at least in New Zealand, would say if you order the test, you're accountable for actioning the result. In other words, you are accountable for citing the result and then actioning anything that is required to be done. Now, you can delegate that responsibility, and indeed our emergency department does. They have someone rostered every day to review, sign off, and action all of the ordered tests for the day before, because they've faced this issue. And they have a lot of locum people coming across, and it's not possible for those emergency room doctors to sign off their own results. So there are, workarounds like that, because there's no hospital or health system in the world that has completely nailed the accurate routing of laboratory results to someone who actions them. I researched this a few years ago, and it's a very, very challenging issue. So you end up with trying to get your systems as resilient as possible and your IT systems talking to one another. But most hospitals employ a lot of clinicians. There are lots of different orderers. They rotate around. Junior doctors particularly rotate around. People retire and they move on. They don't necessarily, put in change to the system. And so there has to be some redundancy. There has to be a backup and maybe a workaround within a specific department or a division of the hospital that allows these results to be caught. And then ultimately you can have reports of unsigned results that can be sent to heads of departments who can allocate out, or if they really want to, sign them off themselves. So you've got those backups in the system. But it is very challenging.
And then you bring in, as you mentioned, public health, particularly if a contagious disease like tuberculosis. The laboratory may well pass it on to public health, who have the responsibility for finding the patient in.
In our system, they do, and I believe they do that across New Zealand, but I can't say what they do in Australia. But that adds a layer of redundancy as well, because as soon as the public health service has the positive result, they can directly contact the patient and start the contact tracing if the patient is infectious.
You indicate that this would be a critical incident. What sort of ISR level would you assign a missed test result like this?
Well, it depends on the harm. In New Zealand, the definition of a sentinel event really depends on the outcome. So the potential for harm here is not just the individual, it's the potential for harm to the community. For example, if the infected person infected a small child, particularly a child that had not had BCG, and they contracted tuberculosis meningitis, that would be a sentinel event of probably 2 or 1 if it was lethal. So it really does depend on the harm. I find that classifications that rely on an outcome are not nearly as helpful as classifications that could rely on potential for harm. And in this case, it's not just potential for harm for one individual, it's potential for harm to a community. So I find it difficult to classify. But I would investigate as though it was, in New Zealand, a serious adverse event, class 1 or 2.
You've mentioned the trauma to the emergency doctor in discovering that the results haven't been followed through. Can you talk to us about how you would approach this doctor and the sort of conversation you'd have with them?
Yeah, as I said earlier, I would apply the principles of just culture, which is a blame-free approach, an approach of supporting the doctor, because I have never yet met a health professional who is not devastated in finding themselves in this circumstance, and advise that we'll be supporting them through a process of investigation, discovery and improvement. I will be keeping an eye open that there isn't a performance issue, because sometimes that is revealed in the course of the investigation, but I very much support the doctor. If I'm concerned about the doctor, then I would apply a buddy system, someone who he either works with or relates with, maybe in another place of employment, that can be someone he can talk to. And we also have employee support services to check in on individuals' welfare. There are well-described cases of second victims where there has been an omission or an adverse event, even where there has been no failure to deliver excellent care, but a system failing has occurred, and those second victims are profoundly impacted. So I would be very careful about maintaining this doctor's well-being.
I'd like to turn our attention to the patient. Their conditions clearly progressed over the 3 months. What do you tell the patient?
You tell the patient what you know. It's the how you tell it that is really important. The patient's itinerant. We don't know what ethnicity, what culture, what supports, what language, and we might have difficulty finding this patient if he's itinerant. So we may need to rely on some social work assistance. But I would be very much looking to bring, if necessary, cultural or language support along at the same time. And I would simply explain to the patient what has happened. I would apologise. I would say what we are going to do about it, and both in terms of making things right for the patient, treating the tuberculosis, ensuring that the community in which he resides and the people he is close to are also looked after, because they will be the primary contacts, and ensuring that he understands what we're doing. In New Zealand, of course, we have no fault insurance, so we all feel a lot safer having those conversations. We do not go into those conversations with lawyers. In Australia, it's an entirely different matter, and you will probably take legal advice before you have that conversation. It doesn't absolve you of the responsibility to have it, but at least you know where you stand, and then you appropriately guide it in any conversations that might arise around redress of that in a financial sense.
So when do you inform your insurer? And I guess in New Zealand, when do you notify ACC?
The notification to ACC is made by the doctor who will take over the care, which would probably be, in this case, a respiratory service. There is no primary practitioner. ACC would be notified. We would also generally guide the doctor who ordered the test to contact their own insurer Not that they will necessarily ever have to face a claim, but very, very occasionally a patient will seek damages over and above ACC.
And of course, in Australia, we would let our insurer know very early on in the process.
Of course.
So you undertake you set up an investigation. There are, if you like, failures or challenges at several levels, not only in the emergency department, the hospital's processes, IT, notification, but you've got the laboratory as well. Do you bring all of those parties in to the single investigation, or do you suggest the laboratory run their own investigation and tell you the outcomes?
I don't believe the laboratory should run an investigation. They received an order. They processed the result. They sent it to the auditor. If there was an expectation to send the result to public health, we don't know from this scenario whether they did or did not do that. I think it's important to keep the investigation team of a size that is appropriate. We often have neutral people, but experienced in the various realms. So I would be looking at having a clinician auditor who's senior, but not the doctor, but understands the emergency department. I would be looking at having someone from the laboratory, only because they understand the systems, how the results are joined up, the electronic systems joined up in this case. I would be looking at having an improvement or a safety expert from the safety team, but I work in a hospital that's large enough to have that, of course, and it's hard for, if you're working in a smaller hospital or remote hospital, to have that person, and then having a scribe and a senior leader who can sort of navigate the conversations, who's experienced in either root cause analysis or some of the other tools we use to investigate adverse events. And that team would then gather information, interview the relevant people, look at the systems involved, maybe talk to some of the IT managers who support laboratory systems, how they interface with hospital systems for physicians' inboxes, for example, where the results are routed, what are the sign-off signals, etc., etc. I would expect that team to take into consideration the regulations and guidance for laboratory sign-off, the accountability framework for that, so they understand where they're working, what they're working within. And I would expect them to, again, apply the culture principles, but take it very much what happened, what normally happens, and what would we like to happen in the future. Then, with that information, they can devise a series of recommendations for improvement, which should then go to the hospital management and leadership team to consider implementing.
Both Australia and New Zealand have health complaints commissioners, or HCCC, to whom any patient can write if they're unhappy with the service provided. How does that interface work, and does it influence the investigation you undertake?
It depends whether or not there has been a notification in the New Zealand case to the Health and Disability Commissioner, either by the patient or the family. But even if there has been, we will conduct our review independently. But the information from that we will usually share with the Commissioner if they request such, and they often do. Where there is an adverse event resulting in death, we would often share that with the coroner as well if they ask. So we are relatively open about that, probably working in a system with no fault, a no-fault insurance system. It makes it a lot easier, but we may be asked by the Commissioner to supply further information, as the Commissioner may take her own independent investigation. But where we've undertaken a thorough investigation ourselves, they would generally accept the findings.
Yeah, and can be very supportive if the hospital's undertaken a robust investigation,
yes,
which can be very helpful.
But I would make the comment that where you have an early meeting of open disclosure and a policy of an apology, and where you're open and where you support the affected individual in terms of cultural support, family support, community support, etc., those complaints to an external body are greatly reduced.
I'd like to come back to the issue of just culture. No doctor or staff member in an emergency department works in isolation. And the other staff in the department are going to form opinions about this patient's care and the doctor who didn't look at the laboratory results. How open and transparent are you with the other staff in investigating this incident, particularly in the context of confidentiality and implications for doctors' reputation?
It's a difficult one because when you're undergoing the investigation, you're not always certain about the outcome, and particularly you can't be certain about matters relating to competence and performance of duties. So there is a need for confidentiality, but we then have a process of open sharing of the reports. And that's when we go to the department and say, this is what we've learned and this is what we are doing. We also promulgate the just culture at an organisational level so that our staff understand what will happen in an adverse event. They understand why it's important to report incidents and understand that we will investigate these under the principles of just culture. And that, I think, is culturally important for the organisation, so staff appreciate that they will feel safe if something goes wrong. Because if they don't report, they're hiding. They're not only hiding things that go wrong, they're hiding the near misses. And it's the near misses that we really want to know about.
Thank you, Margaret. That's been excellent. Do you have any final thoughts or observations about the challenges of missed test results?
Ultimately, it does come down to both the orderer and the hospital and its systems doing their bit. And we can, as clinical leaders and medical managers, can really lean on the hospital managers to invest not just in the systems, but also in the improvement science and teams that are going to be necessary to deliver the necessary ideas for, improving our systems. But we can also, through clinical leadership, lift the performance of our clinicians to ensure that they report incidents, ensure that they feel safe in a just culture, and that they do work hard to sign off their results. We do have pockets of clinicians who are tardy in signing off results, and so it's clinical leadership, it's sharing of the stories of why this is important that enables that behaviour to slowly change. So keeping on top of results sign-off and having reports on how many are unsigned is a good way of just checking in how the organisation's managing that. As I say, no organisation is perfect. And if anybody out there has got this right, I would really like to know.
That was Dr Margaret Wilsher, a respiratory physician who spent 13 years as the Chief Medical Officer at Auckland City Hospital. And that brings us to the end of this episode of Safeguarding Healthcare. I'm Dr David Rankin. Follow Safeguarding Healthcare free on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen to podcasts. This podcast is produced by Sound Cartel for the Royal Australasian College of Medical Administrators.